Hi, good evening, everybody. Welcome to another session of our webinar, which we've been doing for a year now, quite diligently. And thank you for your support and coming over and over again for this all our webinars. Some are really regulars, and we have here with us, I think we have had a cancer talk before, but it was a palliative talk by Dr. Felicia Chang. We never had a real cancer talk, and this is very very important for both the public and the GPs, because they are the first people who may come and screen the patient. So we have here with me Dr. Junie, my colleague. Okay, Dr. Junie is a clinical oncologist with Beacon Hospital. And without further ado, let me allow you to share screen. You want to try to share screen?
Yes, let's try. Yeah.
Did you get the hospital to change your surname or not, Junie?
Yeah, they did.
Okay.
Yeah. I'll just start.
Yes,
thank you, everyone. Thanks for joining us tonight. And I'll talk a little bit about cancer screening and prevention, and I'll touch a bit about treatment later on as well. Thanks for having me, Betty. And without further delay, I'll just start on my slides. So first and foremost, what is cancer? So basically, from the far left, you can see these are normal cells. They are very well aligned. They are very normal in shape. And some mutation can happen, genetic changes can happen to the cell, and these cells become abnormal and they start to proliferate. They have uncontrolled growth and it can grow very rapidly. When they multiply, they can invade and into adjacent tissues, organs. For example, from the intestine, it can invade into your liver or your spleen, which is adjacent to it. It can invade into lymphatic systems and go to the lymph nodes. And of course, it is well known that cancer can metastasize to distant organs, and the commonest sites would be brain, lung, liver, and bone. This is usually by the bloodstream. The cancer cells get into bloodstream and follow the blood to anywhere, and then they start growing from these places. So a little bit about how this happens. In a normal condition, we have proto-oncogenes, just a fancy name for areas of genes that actually control our cell proliferation. Cells, we know they will grow to a certain extent, and some cells that are too old, they will go into death cycles, and the adjacent cells that are normal will actually grow and build new cells. So areas called proto-oncogenes are actually designed to start on the cell replication and proliferation. So they are actually stimulated by growth factors that attach onto receptors and tell the cell you need to grow and need to proliferate. So sometimes some cancer-causing agents or carcinogens, as we say, it can trigger certain part of this proto-oncogene and mutate it. It becomes an activated oncogene, onco as in cancer. So this will convert the normal cell into a cancerous cell, and then these cells will go haywire. They will sort of run amok, and then they will start proliferating uncontrollably. So this is what a normal cell look like with a normal gene sequencing, and a cancer cell, they will have this oncogenic aggregation and accelerated cell growth and division. So our normal immune system actually has a counter check system. We call certain genes called tumor suppressor genes. It acts like a brake pedal, basically. If they find that there are certain cells that are growing uncontrollably, they will actually start to produce some inhibiting factors to make the cells stop growing. Either they go into repair, they counter check what is wrong, repair it, and then if the cells cannot be repaired, then they will put a time bomb to it. They will induce the cell actually to go into apoptosis. But in a cancer malignant condition, a lot of the time these oncogenes get too much, they cannot be controlled, and our immune system cannot countercheck and cannot stop it or kill it off. So these cells will actually proliferate uncontrollably and invade and metastasize. So there are certain hallmarks of cancer. Why we say these are cancers? Because they can resist death, they can induce angiogenesis, means they try to get nutrients from other places by making new blood cells to supply them for their increasing need for growing. They are able to divide uncontrollably and immortal, so they keep on growing and growing and growing. So they can invade and metastasize, as well as even though you have growth suppressors, the cells actually don't stop growing. So before we can know how to prevent cancer, we need to know what could trigger the cause of cancer, what could be the things that can actually induce you to have this mutation and genetic changes that makes cancer grow. So genetic changes in the proto-oncogene area that is unchecked that will induce the cancer happening. It can be inherited. It is not very common, but there are 5 to 10% of the time can have repair mechanism issues, things like BRCA and Lynch syndrome, neurofibromatosis. These have underlying repair mechanism deficiency. So they are more prone to get abnormal mutation that is triggered from the environment, for example, and then it cannot be counter-checked and cannot be repaired, and then the cells will go into cancer cycles and spread. Some of the environmental exposures can trigger cancer forming or induce mutation. Things like aromatic dyes that you can see can induce things like bladder cancers, silica, asbestos. Asbestos is used a lot in the 60s and 70s for ceiling building. So when construction workers, for example, take down buildings, so they are exposed to asbestos, and then in that sense, when especially coupled with smoking, they are at 20 to 30 times higher chance of getting mesothelioma, which is a type of cancer of the lung linings. So we have viruses that can induce cancer, for example, human papilloma virus, Epstein-Barr virus that can cause things like NPC and certain lymphomas. HPV is associated with cervical cancer. Hepatitis B and hepatitis C viruses can induce inflammation and cirrhosis of the liver, which in chronic infection kind of form, they can actually induce liver cancers formation. Radiation is also a risk for cancer forming. So things like nuclear exposure after catastrophe, as well as patients that are very young, they are exposed to radiation. For example, children with acute lymphoblastic lymphoma, for example, they can have a radiation to the mediastinum or the chest area because of a tumor in the mediastinum. And after 20 years or so, they are at higher risk of getting breast cancer, for example. Other things like lifestyle can actually also predispose you to get higher chance of getting cancer. Smoking is associated, more than 80% of the time, lung cancer is associated with smoking. Smoking can induce other types of cancers as well. Obesity is related to near 10 types of different types of cancer, including colon, breast, etc. Alcohol can also induce cirrhosis, which in turn can also can cause liver hepatomas, liver cancers. So approximately 19.2 million new cases per year in the world of new cases is detected. 50% of them would be in Asia. That is partly because we have the highest population in the world. About 10 million deaths recorded per year. These are data from the Global Can, which is a part of a WHO kind of data. So Asia countries have the highest mortality because partly because we detect cancers very late, and then poorer economical status confers inability to afford a better treatment plans. And a lot of our patients actually go on for alternative treatment. They can see BOMO, they can have vitamin B17 kind of treatment rather than go for oncological treatment. The top 5 tumor types would be lung, breast, colon, prostate cancer, and stomach cancer. But the highest mortality still remains is lung cancer, followed closely by colorectal and stomach cancers. So what about locally? Malaysia has about 32 million people population. Every year, near 50,000 of them will be detected having a new onset of cancer, and 60% or near 30,000 of them die each year from cancers. The top 5 would be breast cancer, colorectal cancer, lung cancer, nasopharyngeal cancer, and liver cancer. But there's difference amongst males and females. Lung cancer is still the highest mortality among all cancers, and amongst male, it is number 1 commonest cancer, followed by colorectal and prostate cancer. And in females, about 1/3 of all new cancers detected in females are actually breast cancers. The second is also colorectal cancer, followed by ovarian, cervical, and endometrial cancer or uterine cancer. So I talk a bit about screening. So as you heard before, the top 5 commonest cancers would include breast, lung, colorectal, cervical, and prostate. And all these type of cancers, actually, we have very good screening programs. So I talk first about breast cancer. So the easiest and the commonest thing that you can recommend to your patients is actually breast self-examination. Patients that are premenopausal, you can do breast self-examination 7 days after the period when the breasts are not so dense and heavy. And if the patient is postmenopausal, you just ask them to choose one of the day each month and stick to that day, just do an examination. It's very easy to do. You just need to stand in front of the mirror, or when you are lying down, or when you're taking shower, just have a look and see whether they are balanced, whether there's anything protruding, anything pulling it in, any new lumps and bumps, and then with changing of position and raising and putting down your arm, whether there is any change in that. So if you feel something that is not really right, then the patients should actually go seek for help, look for either GPs or see a breast surgeon, for example, for examination. So common things will be a hard lump, changing in size or shape of the breast. Then there is skin changes. Sometimes we call pudorage, which means like the skin look like orange skin, like some small dimples on top. It can look engorged, it can look reddened. Even sometimes some patients have discharge from the nipple. Sometimes they have some skin changes like rash kind of things overlying the lesion. Sometimes the nipple actually get retracted or contracted. Sometimes we get dimpling of the skin area because of the pulling from the tumor site. 70 to 80% of the time, lumps from cancers are painless. So need to be aware, especially for the public, is that painless lumps are actually more dangerous. You should get it checked rather than just leaving it. Most of the time, cancers are painless. It can happen in the breast and it can happen in the axillary or the armpit region. So in YouTube and pamphlets, there are lots and lots of them, and it's easily accessible. So the other part of breast screening would be things like mammogram, ultrasound of the breast, or MRI of the breast. Younger patients tend to have denser breasts, so it is recommended if you are less than 40, you should do an ultrasound. And if you're more than 40, when there are more fatty tissues in the breast compared to a dense, fibrous kind of breast, you should do a mammogram. And this is how we do a mammogram. Basically, it's just a machine with an X-ray built in. Some GPs actually have X-ray machine, and some the small screening centers, they may have mammogram machines as well. So basically, the breast is placed there, it is pressed on, and then you get an image of X-ray. Cancer will have typical microcalcification that indicate a nodule and may warrant investigation. If it is normal consecutively, then you can repeat every 2 yearly. After 3 years consecutive negative, then you can do every 2 to 3 years yearly. October is actually Breast Cancer Awareness Month. So many hospitals, including Beacon, would actually have sort of a promotion kind of thing. So the cost of a mammogram, which can cost from 120 to 150 ringgit, is cut down drastically. Some centers like NCSM, they also offer free mammogram screening for this month. So you can let your patients know they can go for all these free or hugely subsidized mammograms. The other one is lung cancer. So patients can present with things like cough, difficulty breathing. Coughing up blood is a particular special kind of indication that should indicate investigation if can. So repeated infection can happen. Some patients have pain, especially if the cancer has spread to bone or things like that. They can have persistent bone pain. So if you have unexplained weight loss, loss of appetite, things like that. It could be a constitutional symptoms, but mostly would indicate actually a stage 4 disease. Patients can have other things like hoarseness or salt imbalances. SIADH is also very prevalent amongst lung cancer patients. Many of times patients are asymptomatic. That's why lung cancer is one of the cancers that is detected very, very late. 90% of patients actually come in at stage 3 and stage 4 in Malaysia. So smoking is the cause of up to 80% or more of lung cancers. Some is occupational exposure like asbestos, chromium, silica, things like that. If the patient smoke, they may or may not get the cancer, but family are at risk because they get secondhand smoking, because they smoke at home or in the car. Air pollution plays a role. Patients have a COPD for a long time, so there's chronic inflammation of the lung. They also have higher chance of getting lung cancers. Alcohol and obesity are linked with lung cancers as well. So smoking has lots and lots of carcinogens inside, and vaping also is shown to have multiple carcinogens inside. Some patients in Asia are actually never smokers, but also they have exposures to things like cooking vapor that use coal or wood and incense kind of thing to cook and things like that. And secondhand smoking is also a common risk. And screening for lung is actually very simple. You do a low dose CT scan. So the CT dose is actually very minimal. It's very quick. You don't even need to give contrast. It's only 3 to 5 minutes. You just lie down in the machine. They screen through very quickly and see and locate whether there's any nodules in the lung. So if they find something, then you may warrant for further investigation under the respiratory physician, for example. So there are certain groups we think there are higher chance of getting lung cancers, patients that are 55 to 75 with a history of more than 30 PET years. Just to refresh, 1 pack year means you smoke 1 pack of cigarette per day for a year. So if the patient smoke 2 packs per day, so if they smoke for 15 years, 15 times 2 means 30 years, then they would be at high risk of getting lung cancer. Or if they have quit less than 15 years ago, they are still considered a higher risk of getting lung cancer. You can refer them for screening. So many hospitals also have subsidized low dose CT, especially for Lung Cancer Awareness Month, which is in November next month. Colorectal cancer is the second commonest cancer amongst males and females. So how do it happen? Usually they start off with a small polyp. We call adenomatous polyp. Then as time goes by, it grows bigger and bigger, and areas can get dysplasia, abnormal cells starting to form, and later on it can invade into the underlying tissue, especially the muscle layer, and become an invasive tumor. So when you do a scope, you can see these are actually polyps. You can start off small polyps like that and grow with a peduncle, sort of a stalk like that. Some tumors get bigger and more fleshy. Sometimes they can bleed on top. And when you do a colonoscope, actually, you can actually do what we call a polypectomy. They snare off and remove the whole chunk, and then they send off for HPE. Sometimes these are just normal polyps. You don't have to do anything. Removing it will actually prevent it from turning into cancer. And it's part of treatment if the patient have very, very early onset of cancer. They may not need to have major surgeries or adjuvant chemo, things like that. So patients can come to you with altered bowel habit. So they can say a few days they will have severe constipation, then suddenly diarrhea for a few days. So the change is there. Sometimes the stool becomes smaller and smaller in size because there is more obstruction of the intestine. They can complain of blood in stools or a lot of mucus discharge. This one is usually related to tumors that are lower lying, like in the distal part of the colon, sigmoid colon, or the rectum. Some patients actually present with abdominal discomfort and pain. And another thing to watch out is actually the patient can go into intestinal obstruction or even perforation if the obstruction gets so severe. Stage 4 patients can have constitutional symptoms, weight loss, appetite low, and then they can have bone pain if it's spread to bone. So any patients that is not actively trying to lose weight, going on a diet, do exercises and things like that, but complain to you, recently eating still quite normally, but weight still keep on dropping. Anything more than 10 to 15%, you warrant investigation. Refer to a center, can do upper and lower scope or get a scan done. There may be occult malignancy that is not detected and they present itself with actually constitutional symptoms. Sickle cancers tend to not have a lot of symptoms because that area can actually expand very largely. So they may not have intestinal obstruction kind of symptoms even until very late stage. But one of the hallmark is that they can present with anemia. So patient can have lethargy, like reduced effort tolerance, palpitation, and then dizziness, things like that from the chronic blood loss from the tumor. So this I will just go in very briefly. Familial syndromes can be inherited, but it's actually very rare, less than 5%. Things like familial adenomatous polyposis means the polyp that we see earlier on is the carpet full of polyp throughout the whole intestine. Each polyp has the chance of turning into cancer. So when you have that many polyps, of course, you're at a very, very high chance of getting cancers. So these patients, if we detect them, the whole family actually need to get screened. Sometimes we do things like elective or what we call a prophylactic total colectomy, remove the whole colon, so to just treat the whole area and prevent them from getting cancer later on in life. Other things would be Lynch syndrome, for example. They are also at a high risk of getting other cancers other than colorectal cancers like uterine, stomach, ovarian, and kidney cancers. So patients that have ulcerative colitis or Crohn's disease, those that have a prolonged inflammatory kind of disease, they can have higher chance of getting cancers, and lifestyle as well, high in fat, red meat, processed meat, obesity, cigarette smoking, all these are associated with colorectal cancers. So the screening basically is one, fecal occult blood, because they can have blood in the stool. Sometimes the blood is not apparent on a normal stool, but it can be there. And the other one, gold standard, is actually colonoscopy. We look and hunt for polyps, and FAP and Lynch syndrome, they may have multiple polyps and they need to be treated. We need to screen them earlier on. Some patients actually don't have any symptoms, but just routinely they have a blood checkup and noted that it's a raised CEA, a tumor marker. Then they go on for investigation. CEA can be raised in many other types of cancer other than colon cancers. So during the colonoscopy, which is what we see in the picture here, there is a camera set into the scope, put in from the anus area all the way up into the ileum area, just right entering just near to the ileum, and then the surgeon usually or the gastroenterologist will have a look all along the way whether there's anything, and at the same time if they see a polyp, they can do a polypectomy, or if the lesion is too big, they can take in a biopsy to confirm whether this is a benign disease or cancerous disease. So Ministry of Health actually came up with a very good guideline. The CPG for colorectal cancers is free for download. It's very easily accessible with Google. You just check, then you can get it PDF file free. So basically you need to assess the patient whether they have symptoms. If they don't have symptoms, you see whether they have risk factors from family history. Then they have different categories, whether they are average risk, moderate risk, or high risk. And then from there, you see what kind of screening that you can offer to them. So risk categories for family history with colorectal cancers would be one, average risk. So there's no family history, patient is more than 50 years old, you can just do a fecal occult blood and then screen for that, like what I saw just now. So you can repeat yearly if it is negative, then if it is positive, then you refer for scope. So if the patient has moderate risk, means they have first degree family members that have cancer. So you can screen them at age 40 or 10 years younger than affected relative. Means if the relative had colorectal cancer, the first degree relative would be your parents, your siblings, or your children. So if they have the cancer at, let's say, 60 years of age, then you can start screening them at 40 years. Or if they have cancer at 40 years old, for example, then you start screening the patient at 10 years younger than that. So if they're 40, then you start screening them at 30 years old. Okay. So if high risk, if they have a family member that has colorectal cancer less than 50 years of age, or if they have certain hereditary issues like that, then you need to screen them at age 40 or 10 years younger than the diagnosed age of the family member. And there are certain things that you do. So if normal, then you repeat every 3 to 5 years. So this is actually the other algorithm. So you ask the patient whether they have any signs and symptoms like rectal bleeding, loss of appetite, irritable bowel habit, etc. Then you take the history. Then if there is bleeding, or patient has presentation of anemia, then you refer urgently to do scope within 2 weeks. If not, then you treat the sign and symptoms and then refer within, if the symptoms not resolved within 4 to 6 weeks, then you refer also for a colonoscopy within 4 to 6 weeks if the symptoms do not resolve. So the next one is cervical cancer. Top 3 for the third commonest for female cancers. So patients can have things like intermenstrual bleeding, postcoital bleeding, so postmenopausal bleeding, or patients in the late stage of constitutional symptoms, they can have pelvic pain, they can have vaginal discharge. So if it invades into the adjacent tissues like bladder, they can have bleeding from urination, they can have frequency and pain, they can have back pain, they can have bleeding from the rectum as well because of tumor invading into the rectum area. Some patients actually have a lot of lymph node metastasis in the pelvis that will increase the pressure in the abdomen and cause leg swelling as well. So screening is actually very easy, has been around for many, many years. Pap smear, it's easy, it's fast, almost pain-free. You do a speculum, then you put in a brush or a spatula, twist this around because cervical cancers happen at the epithelium, just at the junction between your cervix and the endometrium, the uterus part. So then it's just put into a formalin fixation, and the lab will actually look for any atypical cells. So if you do consecutively 3 years is normal, then you can do every 2 years. So last but not least, prostate cancer. It's very common in the elderly, especially. Many patients will present with actually things like lower urinary tract symptoms like frequency, nocturia, hesitancy, the urine stream get less and less. So it's like prostatism kind of symptoms. The doctor can just do a digital rectal examination to feel whether this area is actually swelling or irregular, whether it is painful or not. Some patients actually take PSA as part of their health screening kind of thing. It's quite sensitive. It is excessively high. It can indicate actually a presence of prostate cancer. So tumor markers is very commonly done, especially it's a lot of part of the health screening kind of blood test that we do. It is not always very accurate. Some patients have cancer, like stage 4 cancers in them, but tumor markers are still normal. But some patients that have no cancer in them, they have some autoimmune disease or they are smokers, they can have slight elevated tumor markers as well. So it's not a very accurate kind of test, but sometimes it helps because if it is high, it may prompt patients to go for further investigation. Breast cancer can have CA153, CEA or CA125 raised. Things like CEA is associated more with the GI or adenocarcinomas, like in the lung, stomach, colon, even sometimes in the breast, CEA can be raised as well. CA19-9 is more specific for the pancreatic area or even biliary tract cancers. Ovarian cancer is more a CA125. Anything in the pelvis, most of the time is CA125. Testicular cancers can have raised alpha-fetoprotein and HCG. It's not something very commonly done in as part of screening, but it's useful to prognosticate patients with testicular cancers. So what can we do to prevent having cancer? First and foremost, the most important thing, tell your patients or even you yourselves to stop smoking. Actually, smoking kills. It's associated with lots and lots of cancers as well as lots and lots of other disease. Tobacco chewing like sirih, things like that for Indian and some indigenous people in Sabah and Sarawak, they have this tobacco chewing. They can be associated with a lot of oral cavity cancers, squamous cell carcinoma specifically. And secondhand smoking, you can actually induce lung cancers for your children or your spouse if you smoke, especially if you smoke at home or in the car. And there are a lot of quit smoking clinics, including some GP clinics as well, and strategies available to help you stop smoking. Eating a healthy diet actually helps as well. Vegetables and fruits mainly. Try to keep a healthy weight. Obesity is related with many types of cancers. Then if you take alcohol, take in moderation. Do not binge drink if possible, and try not to take too much because it can induce issues like liver cirrhosis. And processed meats are usually have a lot of chemicals and preservatives, and they are associated with a slight higher chance of getting things like colorectal cancers. So things to avoid would be things that have a lot of preservatives and things like instant noodles. They can have a lot of carcinogens in a lot of this type of food. So maintaining a healthy weight and staying physically active is important as well. Obesity is linked with various types of cancers. Physical activity helps to control weight, stay in shape, improves your immune system. Immune system is important for counter-checking whether there's any abnormal cells to kill them off and keep you healthy. And endorphins actually improve your mood as well as makes you feel good. Vaccination is the other important thing. So we know hepatitis B is associated with actually cancer. It's a DNA virus. Infection can be acute. You can actually get well and cured from after a hepatitis B infection. But some go on to develop a chronic infection, meaning they get into a carrier status. The younger you get hepatitis B, the higher the chance you get into a chronic infection compared to when you are exposed to the hepatitis B at older age. It can induce cirrhosis and then in turn can cause liver cancers. It can be sexually transmitted and transmitted via blood, saliva, and bodily fluids. And it has been part of our national vaccination program since the 80s. So children, infants, basically after delivery, they are given actually doses of hepatitis B. So some patients go for health screen, they check for antibodies. If it is low, they can be offered booster injections. So the other one of very important is actually human papilloma virus. It's a big family of virus, more than 100 strains of virus, but certain strains are associated with some disease like warts, HPV type 6 and 11. Some are very high risk. They can induce cancers, things like cervical cancer, vaginal or vulvar cancer, penile cancer, anus cancer, and oral cavity cancers, oropharyngeal mainly. Squamous cell carcinoma is associated with HPV because these are actually from sexual transmission, oral sex, anal sex, and normal sexual intercourse. So there are many variants that can induce cancer with the highest risk of HPV strain 16 and 18, and which is actually attributed to 70% of all cancers and precancerous lesions that is detected. So HPV vaccine has been introduced to our healthcare system, to our national vaccination since 2012, and girls of 13 years of age are actually given free vaccination. There are 3 different types of HPV vaccines comprising of either 2-strain protection, 5-strain protection, 9-strain protections, and those virulent strains that can induce cancers are usually the ones that are used to make these vaccines. So anybody less than 45 years of age are still advocated, if can, to get vaccination. Males or females can get vaccinated, but the program currently in our national vaccination program offers only for females. 99% of cervical cancers are actually caused by HPV. So the other thing is avoid risky behaviors. We know sexual transmission, we can have sexually transmitted HPV and HIV, hepatitis B and C as well. HPV I've mentioned. HIV has a host of cancers related to that, including Kaposi sarcoma, certain types of lymphoma like diffuse large B-cell lymphoma, Burkitt's lymphoma, and there are AIDS-related CNS, the brain kind of lymphomas that can happen. So hepatitis B and C can cause hepatocellular carcinoma. Intravenous drug abuse using needles, if it is shared, it can transfer all the viruses, and then that can cause cancers. And going for tattoos and acupuncture, you need to make sure the needles used are either once used and discarded, or if you go for tattoo, the place that you go to, whether it is a high-risk place or do they do a very safe kind of hygienic kind of tattooing. Sun exposure, it can induce skin cancers. Try to avoid midday sun, stay in the shade, cover yourself with hats or long sleeve clothes, use sunscreen. So higher risk for Caucasian people because they are at higher risk of getting things like melanoma compared to Asian. So doing regular medical checkup is important. You go for your screening once a year, things like that. Improve the chances of detecting cancers early. And if detected early, treatment usually is very, very effective and can be successful in curing the cancer. So once there are certain abnormality or lesions noted, what do you do? So the doctor, you need to refer to a center that has expertise. You do physical examination. There are certain blood tests to see organ function, tumor markers, things like that. And the other thing, most important, is to get a biopsy to confirm whether this is cancerous or whether this is a benign disease. We confirm which type of cancer because there are different subgroup kind of cancers. Even in breast, there are many different types. Treatment can differ from there. So if the lesion is actually very superficial, like lymph node, skin, or breast, you can just do a needle biopsy. If it is deep-seated, then you might need help from a CT guided or ultrasound guided, usually by our intervention radiologists, for example, lesions in the lung or in the liver. So we may call in help from the gastro or respiratory physician for scopes, nasal scope, oral scope, OGD, colonoscopy, and bronchoscopy, for example, and biopsy from there. Or if it's not accessible, the surgeon may need to go in for a surgical resection and get HPE from there. So after that, we will do certain things like scans, x-rays and ultrasounds. Most commonly is actually CT scan, thorax, abdomen, and pelvis, or MRI. MRI is useful for places like the brain or tissue like prostate and rectal tumor. Sometimes we want to see the tissues or whether the vessel and lymph nodes are involved, how close is the margin to the sphincter in the anus, for example. PET-CT is the other one we do very commonly nowadays. And what is the difference? So you can see CT is conventional 3D images. You can see anatomical changes, whether it's abnormal or normal. The good thing about PET scan is you can see activity in a form of color. Usually the brighter the color, like yellow and red, it means very high activity and usually indicates either active infection or in this case is cancer. So you can see on the left, you can see a small nodule here in the heart area. So there is a lymph node there. And you see on a PET scan, actually it lights up very, very highly, means it's actually a cancer in the lymph node. From the CT scan, the bone actually looks normal, but the PET scan shows that there is actually uptake there and showing that this patient's actually tumor has already gone to the bone, it's already infiltrated into the bone marrow. The other good part of doing a PET scan is that for this patient, she has a lung cancer with lung collapse. So on CT, you can see a big patch of lung tissue collapsed here. We don't know where is the tumor. If you go in for a biopsy, you probably just poke a needle to the nearest accessible part. But when you do a PET scan, you can see actually this is the collapsed lung. The tumor is actually here. So if you take a biopsy from here, you might not get any tumor. You just get necrotic tissue or normal lung tissue. But if you get a lesion from the hot area, you might get detection of the tumor, and then it makes things easier for us to decide what treatment to give. Patient may need to repeat a biopsy if you don't get a sample the first time round. So it's a lot of teamwork. We need to loop in surgeons, you need to loop in radiologists, and then we need to involve the pathologists to get all this done. And we need to know that because we need to know the extent of the disease and what would be the treatment plan and prognosis of the patient before we decide what to discuss with the patient. There are many, many treatment options in whatever stage cancer they are detected in, including surgery, radiotherapy, chemo, hormonal therapy, targeted therapy, and the new kid in the block, immunotherapy. Surgery is the main treatment of majority of type of cancers. It involves removing the tumor surrounding tissue, blood vessel, and the blood supply, lymph nodes. And if it is detected early enough, it may just need surgery, don't need anything else, especially in this early stage. So there are many newer technologies. It used to be laparotomy. Now we have a lot of things that can be done laparoscopically, and robotic surgery is becoming popular, especially for prostate cancer, for example. And things like reconstruction and plastic surgery is actually now very commonly done. So things like patients that have mastectomy, you can take tissue from the abdomen or even the latissimus dorsi, the back side, the back part of your below the scapular area, and implant it and flap it over to the breast area, for example, to make cosmesis better. So that have a shorter hospital stay, for example, they have faster recovery, for example, with laparoscopic surgery compared to laparotomy traditionally. So I talk a little bit about chemotherapy. Chemotherapy basically is drugs. It's sort of poisonous drugs you give mostly in the IV setting, infused into the bloodstream. It destroys the cancer cells, especially those that harbors in the bloodstream, and preventing from dividing and spreading. Different cancers use different combination. There are many, many types of chemotherapy drugs available. We use it in multiple types of settings, whether in neoadjuvant means to downsize the tumor before surgery to make surgery easier, margins are clear, reduce the risk of spreading, or adjuvant means after surgery, we try to prevent the disease from coming back, reducing the risk and controlling the disease, especially for higher risk patients. Palliative setting means it's stage 4, we're trying to control the disease, we control the symptoms, we prolong life. So it can be used in combination with radiotherapy and immunotherapy, for example. There are many side effects, including nausea, vomiting. Certain drugs can cause losing of hair, not all. Some patients have a higher chance of getting low white counts or low red counts. And then we have drugs now for improving the blood counts. Nowadays, we call a GCSF stimulator kind of thing. It will induce your bone marrow to produce new blood cells like white cells to prevent you getting risk of infection. It can cause infertility and early menopause, especially for younger patients. This need to be discussed if the patient is very young, may need for ovum preservation and things like that. It can be discussed. So radiotherapy is the other thing we use very commonly as oncologists. It uses very high grade kind of X-rays, and then we use what we call a linear accelerator or a LINAC machine. And these machines are newer technologies. They actually give very high dose to the tumor without harming very much to the adjacent normal tissue and have lesser side effect. The treatment time now is very, very fast. Sometimes as fast as 3 minutes, it's over. And some, we have special techniques to try to prevent getting more toxicity. It can use in various settings, including post-op, to reduce risk of local recurrence mainly. Some tumors cannot be resected. For example, nasopharyngeal carcinoma or advanced second to fourth stage of cervical cancer, it cannot have operation. So we treat the cancer just with radiotherapy, sometimes in combination with chemotherapy. So radiosurgery is something quite new, quite popular now. So patients get very, very high dose of X-rays to a very small area. Usually these areas are high-risk areas for surgery. For example, brain lesion that is very near the brainstem or the eye, things like that. We can give very high dose and get an ablative kind of effect, meaning as though you do surgery, you just burn it off basically. So patients that have very early stage lung cancers that are not medically fit for surgery, we can do radiosurgery for them, or what we call a SRS and SRT kind of treatment. For stage 4 patients, patients have a lot of symptoms like pain, bleeding, and things like that. Radiotherapy help with the symptom control. Symptoms, side effects are usually related to the local area that you treat. So this is a short video of how our machine works. This is basically the head area. So initially we can do an X-ray, we can get it with the breathing pattern of the patient and sync our treatment to the breathing pattern. And from the linear head actually is where the X-rays come out. This is where the head is, and it changes as it goes around to conform to the tumor shape, and it can rotate 360 degrees. So this will make sure the tumor get treatment that is high dose whereas the adjacent area don't get any treatment very low doses. So for example, a breast cancer patient, the X-ray will beam here to treat the breast. For colorectal cancers, it can rotate around and treat the rectal area. So this stereotactic radiosurgery. So for example, we put in a special head mask and do treatment to one particular small area. For example, this patient actually have a tumor here. It is right next to our optic nerve, and it is very near onto the brain stem. So if you go in for surgery, it is actually very deep-seated and has a very high risk of damaging the brain as well as the nerve around it, and it's dangerous because it's very near impinging onto the brainstem. So we can give very high dose of X-rays here very safely without damaging other parts of the sensitive organs. Stage 4 disease, for example, here we have multiple brain mets. We can give radiotherapy to reduce the swelling in the brain and prevent them from getting bigger. Tumor on the stomach, they can have a lot of bleeding. We can give radiotherapy to stop the bleeding. Patients with bone metastasis and even here fracture, they can have a lot of pain. Radiotherapy can help relieve the pain and stop the fracture from worsening or getting more eaten up by the tumor. So cord compression is another oncological emergency. The tumor, a normal vertebra looks like that on MRI. So the tumor has eaten up the whole vertebral body and caused collapse and compressing onto the spinal cord at the back. So the patient can get paralyzed from this effect, and radiotherapy can try to prevent it. Sometimes we need to go in for surgery and stabilize the spine first, then we give radiotherapy after that. So targeted therapy is also something new, the past 10, 15 years only. So I've mentioned there are certain genetic mutation that happens that can induce the tumor go into hyperdrive and spread and divide very quickly. So targeted therapy is sort of like a designer drug. It target onto the genetic mutation area and prevent either the genome area or the protein that it produces that can control the cancer growing, dividing, and spreading. So there are a lot of research ongoing currently, and there are many drugs available, mainly in two different types. Monoclonal antibodies is usually in IV injection. Then there are targeted therapies we call small molecule drug oral therapy, mostly tyrosine kinase inhibitors. So it's just popping in an oral drug every day to control the cancer. They require the tumor to have certain type of mutation or certain biomarker, as we said. So the patient may need to have certain special biomarker tested or genetic testing to detect whether they have that particular mutation before they can get this drug. So it is less side effect because it's very specialized to certain mutation only. It's very useful for stage 4 disease and maintenance therapy, but it can be very, very costly compared to chemotherapy, for example. Some cancers are very sensitive to hormone, for example, breast and prostate cancer. So we know when the hormone levels are high, the cancers can grow very quickly and divide very quickly. So what we can do is actually try to reduce the hormone level in the body by either giving an injection or oral pill, and this can slow down the progression and prevent from recurrence. So it can improve survival. The side effect would include low hormone level. It means you get menopausal symptoms. So patient can have things like menopausal syndromes and mood changes, bone loss, sleep disturbances, etc. So immunotherapy is something fairly new past 10 years. It has been around for some time, but was not actively researched and used until recently. We know our immune system is actually a counter-checking system. So when there are abnormal cells in the body, they will detect and kill it off. So cancer cells are very smart. They will produce things that help the immune system to not detect it, to evade from being killed off. So this type of drug, they are mainly injection, we call immune checkpoint inhibitors. So they will help the body immune system to detect and recognize cancer and go and attack them. So it uses your own immune system to attack against cancers. So it can be used in multiple different tumor types alone, either by itself or in combination with things like chemotherapy and radiotherapy. So sometimes drugs cannot really help the patient anymore. So what we do for stage 4 advanced stage patient, they may need more like tender loving care and supportive measures. So we introduce things like palliative care. They help with pain control. They give physical and social mental support to the family members as well as patients. And when the patient go into the terminal stage, there are hospice care. Some of them are NGOs and volunteers that actually visit the patient home, loan certain equipments like oxygen, wheelchair, like certain hospital beds kind of thing to help ease the terminal phase of the patients. So in summary, there are many treatment options available for cancer in all stages. There are many newer drugs, machines, and surgical techniques to improve the cancer care, improve the outcome while minimizing side effects. There are many drugs available to improve side effects during cancer treatment. And screening and early treatment allows for better disease control and improved survival outcome. And even in the advanced stage, there are many treatment modalities available to help improve the quality of life, including palliation and hospice. And with that, I thank you for your attention.
Okay, thank you so much. I think it was a very good talk and the timing is perfect. Let me just share what everyone is waiting for. The CPD point QR code. Okay, basically, if you are watching, you can only scan the QR code if you're watching from a laptop and using your handphone to scan with the QR code. You can't watch from the handphone and also try to scan the QR code with the handphone. It doesn't work, okay? Most times you can scan the QR code. Even you can scan the QR code, Junie. And yeah.
Yes.
You can scan the QR code, but for any reason at all, for example, my Miss Dr. Tan Joni, who has always followed our talk, can't scan the QR code. I've given you my phone number. Please WhatsApp me with your name, your MMC number, and your IC number, and your email address, all in one message to me, and then we will send to FISA for manual. Okay, for manual CPD points to be put into your CPD points. We have many questions. Okay, if you are a nurse, I'm sorry to say this, we don't have a system yet. But next week we are doing the first webinar for nurses, and we're trying out this CPD point for nurses. So Dr. Anonymous asks, Junie, what are your thoughts on the widespread inclusion of tumor markers as part of the health screening program in the private sector?
So it is not, it's widely used. It is useful in certain cases, but a negative tumor marker or a normal range tumor marker doesn't imply that you do not have cancer. So you need to take it with a pinch of salt. some patients come and tell me they are diagnosed with cancer, for example, then they go on to do blood tests and tumor markers are normal. Then they say, see doctor, my tumor markers are normal, means I don't have the cancer. It doesn't mean that. It's just a useful tool. When you have the cancer and your tumor markers are high, we can use it very usefully for monitoring. So if we give a treatment, you have a high tumor marker, let's say you have ovarian cancer, your tumor marker is 2000, and after we started treatment, we can see it dropping to 500, 100 to 50, for example. We know our treatment is working. It's useful in that manner. It's not designed to use as a screening tool, but if it is high and you prompt you to go for further investigation, it can have a little bit of value there. Most of the time, the value would be for monitoring response.
I don't know whether Dr. Anonymous is actually asking, okay, your opinion as in, you know, this widespread inclusion of tumor markers, is it like almost a scam or a marketing tool to patients? Is that what you're asking, Dr. Anonymous? Okay, let's go on first before he answer. Okay, XJ asks, Dr. Junie, how do you have any comment on vaping and the risk of lung cancer?
So we don't have a lot of data on vaping and the risk of lung cancer because vaping has not been around that long. Even for smoking, it took many years before data can conclusively say that is actually associated with lung cancer. So the data catching up is actually very slow because you need to be exposed for certain numbers of years and followed up on with a big enough number to say it has that association. But we do know they have a lot more chemicals compared to normal cigarette. So we feel strongly that it has very high risk to induce cancers as much as smoking itself.
Okay, as an extension to Dr. XJ's question, I want to ask whether do you foresee the infection of COVID and long COVID may bring about a risk of cancer?
So COVID has been around only for about 2
Yes.
years. So we don't know actually, we don't have a lot of data on follow-up and things like that. But I feel that things like COPD, chronic infection, they carry even a history of a prolonged TB and reactivation TB itself. So things that has very chronic infection and chronic inflammation, that itself has a higher chance of turning into cancer, especially if you have very severe lung damage from the COVID infection. So likelihood that there is a lot of fibrosis and inflammation that happen during the infection, and after the infection, it can be prolonged. So there is a chance of inducing lung cancer in later future, but we still need to get more information and data from that.
Maybe in 10 to 15 years time?
Yeah, maybe 10, 15 years, we can know a bit
So
more.
Dr. Anonymous asks again, Dr. Junie, does high antioxidant food or supplement help in cancer prevention?
So these are sold as food supplements. They don't undergo things like FDA approval. So we don't really know. We know that our immune system is sustained with, and it's good to have very high antioxidants. That's why we would advocate you to eat a lot of leafy vegetables, things like that. But for a particular supplement that says that they have very high antioxidants, we actually do not know whether it can actually have that effect, because they need to be followed up in a large scale to see that effect. So
and
most of the time,
large scale, but I think they need
they need a clinical trial.
Yes,
for that type of clinical trial that is properly designed. It is not due to chance that they actually get that benefit. So most of the supplements are not sold that way. They don't have clinical trial. They have testimonies instead. So it's very hard to say.
Dr. Casey Nair asks, you mentioned that instant noodle contain carcinogens. Okay, is that for real?
So a lot of preserved food and things, they can have carcinogen. When you are exposed to a carcinogen, doesn't mean automatically you get the cancer. So these carcinogens can induce mutation, and most of the time, more than 95% of the time, your body takes care of it. So you get exposed to a lot of type of carcinogen in the environment, in the sunlight that you go to. So most of the time it gets cleared. So it depends very much on your own immune system, how good it is, how often you are exposed to the carcinogen, how severe is the mutation, and whether it happens in the area that control like the proto-oncogene area, whether it just hit at that area and induce that cancer forming. So a lot of actually chance that happen for that. So it very much depends on your body and exposure. So it's a relative thing.
So Dr. Casey Nair said it's a very common food for Malaysian. Why is it not banned? If that's the case, why is cigarette not banned, and why is sex
alcohol not banned? Yeah.
Hey, you ban sex also without condoms. Okay, so Dr. Casey Nair went on to ask, since HPV is sexually transmitted, would it not be wise to vaccinate the male as well? I think that
yeah, it's a good thing to vaccinate both males and females, especially we want to aim for herd immunity kind of thing. So in places like Australia, they do vaccinate both males and females, like young sort of children lah. They do vaccination below 12 there. So we can see that the number of cervical cancers has dropped drastically in Australia because their vaccination program started off much earlier than Malaysia. So but cost is an issue. So after they find cost effectiveness, maybe the ministry can only afford to vaccinate all the females. If you have children that are males and you want to vaccinate them, you are more than welcome to go to HPV vaccination.
Okay. Dr. Jiling Ki asks, how long can a lung cancer patient, how long can a lung cancer CA can survive without treatment? Oh, I have a patient, female, 60 pack years, who has HPOA, claimed to have weight loss and joint over 2 years. For her, it's impossible for lung cancer if one to have it for 2 years. What do you think? I'm trying to convince her for lung CT. 2 years and cannot convince her for lung CT. Dr. Key, you're not doing a very good job in convincing your patient. Really?
So we quote typical figures. Lung cancers, usually a stage 4 without any treatment, patients survive about 6 months or so. So that is the majority of lung cancers. That is like 90-95% of lung cancer. There are actually rarer form of cancers in the lung that is not the common lung cancers. Things like small cell, non-small cell, those are common lung cancers. We have some called lung carcinoid tumors and other type adenoid tumors of the lung, for example. Those are actually very slow growing. So I'm not sure whether your patient would fall into those categories. Probably some of the more less aggressive form of lung cancer. If it is a cancer, then maybe she has survived so long because it is not that aggressive form of cancers. And some lesion can look aggressive, but unless we get a biopsy to confirm, it may be something benign that is what we call locally invasive, means it grows slowly, but it can be borderline malignant or things like that. So you need to have a HPE confirmation, basically.
Okay, try harder to convince your patient to get a scan.
CT and get a biopsy done.
Or see a... Okay, so now we have Mushana Mustafa, who says, what's the indication for a PET scan? Can somebody just walk in and ask for a PET scan for diagnostic screening? I think not, but Tony, what do you think?
Yeah, no, usually. So there must be some indication for scanning because it's after all you exposed to radiation. So we don't simply just screen a PET scan. Low dose CT is different because the radiation dose is actually very, very low for screening of lung cancer. So usually we need a doctor's letter to say why you want to do a PET scan before we do the PET scan for you.
Well, any screening for anything first must be cost effective, must be safe, and must be readily available. So of all this, PET scan doesn't fit this, criteria. Dr. Ken asks, how should we screen for pancreatic cancer? Is CA 19.9? Is there a DNA screening, testing, or regular EUS for high-risk group?
So unfortunately, pancreatic cancers are one of those sort of silent killers. Most of the time, patients don't have any symptoms and there's no ready screening, partly because it's not a very, very common cancer to get. So a lot of the time, patients come with advanced stage 3 and stage 4, and by the time we know it, there's limited things we can do. Most time, the only way is to cure is for surgery. So if surgery is not available or not feasible, then it is actually a palliative kind of case. CA19-9 can be raised, but it's not very specific. Anything in the biliary tree or near the liver can have raised CA19-9. I've seen breast cancer patients with high CA19-9. So like I said, tumor markers are actually not very, very sensitive or specific in that matter. So there are no DNA testing for pancreatic cancers for now. There are certain treatment if you have pancreatic cancer and you have certain genetic mutation like BRCA, there are some drugs available for treatment for stage 4 disease. We don't regularly do any EUS for high risk group. So if you have symptoms, sometimes patients go for OGD and incidentally find something, or they do ultrasound and incidentally find something. Yeah. And a lot of the time they present with like gastritis kind of symptoms, so get ignored and then they don't do anything for it.
Okay, Bupi asked the minor patients who are at home. Okay, Bupi, this is a whole chapter by itself. And I think Felicia gave us a talk on palliative care and pain management. You can check out our YouTube and you can see the whole spectrum of options there by Felicia. It was a very good talk. Okay. Dr. Chuan Leong Lim. Okay, I suspect the surname is Lim. I learned from CDC for those immunocompetent patients. Because of memory cell effect, there's no need for hepatitis booster once it's confirmed that hepatitis B antibody is produced. Yeah, I think there's no need for booster these days, right?
I don't normally recommend it, but a lot of the time patients say, oh, my antibody was low, my GP already gave me the booster.
Yeah, I don't think it's been a long time coming that you don't need a booster. Oh, can you get the WhatsApp number? I've given you the WhatsApp number. Okay, I'll give again. Can help Fiza ask, kindly help us fill out this CMA survey too. Thank you. Okay. So again, Dr. Chuan Leong Lim says, for a booster, you asked the same question. Okay, we move on. Anything on medical, oh, that's a very good question. Anything on medical marijuana use expected in Malaysia ever? I find this a very interesting one. So what do you think?
So I can only say it is not legal in Malaysia. So we don't use actually medical marijuana for treatment.
But do you believe that marijuana can cure cancer cell? Is it specific to one cancer, or is it a palliative?
To me, more like I'm not sure whether there is actually that good benefit for oncological treatment. So I've not seen any data supporting that for now. To me, there are many other better medication for palliative pain kind of management. So, and we are very comfortable using those kind of drugs because we know for very sure their side effect and how to counteract the side effect, overdosing and things like that. So we don't have a lot of information on medical marijuana, partly because it's never been legal in Malaysia before and not widely used as endorsed by WHO or any international oncological bodies.
Okay. I think it's been very good session, very interactive with a lot of questions and very well answered by Dr. Junie. And I think with that, we end our session today. I hope that you will fill up the forms, the requests by Fiza, who is the marketing, GP marketing of Beacon, to fill up some survey form. And please do like our Beating Hearts page, follow us on Facebook and Instagram, and there are a lot of videos to be watched on the YouTube of previous webinars which we put up. And I think with that, let me see. We'll end the session. Thank you, Junie.
Thank you. Thanks, Betty. Thanks everyone for having me. Goodbye. Have a good night.
Bye-bye. Bye.